Okay, let's dive in. You've handed us some really thought-provoking material today, all centered around making these tough medical decisions.
Especially, yeah, when surgery's on the table for older adults.
Right. So our mission here for this deep dive is to really unpack these sources you shared, pull out the essential knowledge. So you listening can feel, properly informed about what is a complex topic.
It really is. It's a fascinating intersection we're looking at. You've got surgery, these slow-growing tumors, and then layered on top, all the unique things you have to consider when the patient is older.
And the material gives us this great specific case study that brings it all to life.
Yeah.
We're talking about a 78-year-old gentleman called Mr. R in the sources.
That's right.
And his diagnosis of a pancreatic neuroendocrine tumor, a PNET.
And what makes his situation so, compelling is that surgery might seem kind of standard for his tumor type and size, but his age, his medical history, they add so many layers of complexity. It really shines a spotlight on why this geriatric risk assessment, it isn't just, nice to have, it's absolutely critical.
Got it. So let's start with the basics from the material, the diagnosis itself. What do we know about this particular tumor?
Okay, so Mr. R was diagnosed with a PNET. It's in the tail of his pancreas.
Right.
It actually first popped up on scans back in 2023.
Okay.
And then the diagnosis was formally confirmed with a biopsy more recently, early 2025.
And the good news reading through this is that it doesn't seem like an aggressive, fast-moving cancer.
Correct. And that's really a key piece of the puzzle here. The tumor's classified as well-differentiated WHO grade 1.
Okay.
And crucially, its Ki-67 rate, that's a marker for how fast cells are dividing gray. It's very low, less than 1%.
Wow.
So that low Ki-67 tells us this thing is growing very slowly.
Right.
And the imaging over time backs this up. It's been stable in size. Right now, it's about 3.2 centimeters.
So from the tumor's point of view, no 5-alarm fire. How did Mr. R actually report feeling when this is all coming out?
Well, he reported feeling, and this is a quote, generally well.
Okay.
He wasn't having those typical PNET symptoms you sometimes hear about, like palpitations, flushing, bad pain, nausea, losing weight unexpectedly. None of that.
But the sources seem to paint a slightly different picture between how he felt generally and his sort of physical reality.
That's the disconnect, yeah. Despite feeling okay day to day, he has these significant physical limitations. He specifically said he's unable to walk 2 blocks without experiencing shortness of breath.
Okay, it's quite limiting.
It is. He thinks some of it is down to chronic back pain he has from herniated discs.
Right.
And he describes his lifestyle as largely sedentary.
Okay. So chronic pain, being active, definitely factors. Yet the material also mentions he finds much enjoyment in life, even with these limits.
Which is really important, right? It tells you something about his priorities, his quality of life as he sees it.
Sure.
Now, when the clinical team did their objective geriatric assessment, that limited mobility, the low activity tolerance, those were major red flags.
What that immediately signals, and this is key in geriatric care, is it suggests significant deconditioning and potentially very poor physiological reserve.
Physiological reserve.
Yeah.
Remind us, that, again, that's like the body's backup capacity for handling stress like surgery.
Exactly. Think of it like the spare tank in your car, but for your body's systems. Heart, lungs, kidneys, muscles.
Got it.
A healthy younger person usually has lots of reserve. They bounce back fast.
Right.
But as we age, and especially if we're inactive or have other health issues, that reserve shrinks. Deconditioning means his body just isn't used to working hard, so it's going to struggle when pushed.
And his other health conditions kind of added to this picture, didn't they?
They did. His medical history includes hypertension, hyperlipidemia, that chronic back pain, and also obesity based on his BMI. These are what we call comorbidities, other existing health problems.
Right.
And having multiple comorbidities, it really ramps up the complexity and the risk for any big medical intervention, especially surgery.
Because each one can potentially complicate things. Recovery, how the body handles the stress.
But here's the thing that really jumped out from the sources you gave us, the sort of crucial piece. His past surgical experience.
This is where it really hits home.
Yeah.
Mr. R had a very difficult recovery after a much less invasive procedure before, a TURP procedure.
Okay.
He had significant bleeding, needed intervention, ended up in the ICU.
Wow.
and most concerningly, experienced a cardiac arrest.
Oh my goodness.
Now, the exact trigger might be complex, maybe blood loss, needing transfusion, something like that.
Yeah.
But the key takeaway the source's stress is that past event is a powerful predictor.
I see.
It showed his body had severely diminished resilience, very limited reserve, even for a relatively minor stressor.
Right.
Pancreatic surgery. That's a whole different ballgame in terms of stress. Much, much higher.
So connecting those dots from the assessment, what were the main things flagging him as frail?
Well, his age, 78, that's a factor. His limited functional status, those multiple comorbidities we mentioned, the hypertension, high cholesterol, obesity, back pain, they all contribute. But the most significant marker highlighted in the material is that history, that catastrophic outcome after a less demanding surgery.
Okay.
That kind of past event is just a very strong signal for how someone might handle future surgical stress.
We also learned Mr. R isn't going through this alone. His daughter's involved. Shared decision-making.
Which is so crucial in these complex cases.
Yeah.
And they both understood the key facts about the tumor.
Right.
It's slow growing, yes, and normally for this size, surgery would be, the standard recommendation.
Right.
But they also clearly saw Mr. R's age, that prior bad experience, his current physical state, and the sources say they specifically asked for this formal geriatric assessment, precisely to help them weigh the options, keep monitoring, or go for surgery despite the obvious challenges.
And what was the sort of blunt conclusion from that assessment?
The assessment concluded that Mr. R presents as a frail individual. So while surgical resection, probably a distal pancreatectomy for where the tumors was talked about,
Right.
it was considered very high risk. High risk for major complications and even mortality around the time of the surgery.
And the sources give us some numbers to kind of put that risk level in context.
They do. It helps to think about surgical risk in categories. Low-risk procedures might have around a 1% chance of death within 30 days.
Okay.
Intermediate risk, maybe about 5%.
Right.
High-risk procedures, you're looking at closer to 10%.
And Mr.
Based on his assessment, he fell squarely into that high-risk category. Estimated about 10% mortality risk.
And the material made a point about how you communicate that number, right? Framing.
Absolutely. How you frame it for the patient and the family really matters in that shared decision-making. You could say he's 10 times more likely to die than a low-risk patient, which sounds terrifying.
Yeah.
Or you could say there's still a 90% chance of survival.
Right. Different perspective.
Exactly. Both are statistically true. But one emphasizes the danger. The other, the likelihood of getting through.
Yeah.
The critical thing is making sure they grasp the magnitude of the increased risk compared to average.
Let's dig a bit deeper into why the assessment landed him in that high-risk zone. What was the full rationale?
It's multifaceted. First, that history of cardiac arrest after the TUR, that's probably the biggest single factor.
Okay.
It just showed his system's low tolerance for stress.
Yeah.
Second, his poor functional status. The deconditioning, low exercise tolerance we talked about.
Right.
Those are strong predictors of poor surgical outcomes. Things like heart and lung complications, much longer hospital stays, often ICU time, and a real risk of decline in his independence afterwards.
Even if the back pain contributes to his walking limits.
Right. Even accounting for the back pain, the underlying deconditioning from being sedentary is a huge driver of his surgical risk.
And his other health issues played a part too.
Yes. His age, hypertension, hyperlipidemia, obesity, they all add layers to that risk profile.
Yeah.
And a really key point here. Because the tumor is indolent, stable, slow growing for, over 18 months?
Yeah.
There wasn't this immediate oncologic pressure to operate now.
Ah, okay, that gave him space.
Exactly. It allowed the team to really prioritize evaluating and focusing on the significant surgical risks to Mr. R's overall health and life, and weigh that against the potential benefits of just removing the tumor.
So specifically, what were the major risks they foresaw if he did have the surgery?
They were considered very high. The sources list major adverse cardiac events, including, the possibility of another cardiac arrest.
Worrying.
Very. Significant pulmonary complications, too, like pneumonia or respiratory failure, real concerns there. They expected a high likelihood of a long hospital stay, probably starting in the ICU.
Okay.
And critically, a significant, maybe irreversible, decline in his ability to function independently afterwards.
That's huge.
Yes. Plus the other common risks for older adults, delirium, confusion, blood clots, those were noted too.
Wow, that's a heavy list of potential downsides. What about the potential upsides? What were the benefits?
The main potential benefits were, 1, the possibility of curing the localized tumor, by removing it completely.
Right.
And 2, potentially preventing it from slowly progressing or spreading later on down the road.
So boiling it all down, what were the key vulnerabilities the assessment really zeroed in on for Mr. R?
The sources highlighted his extreme physiological frailty, his poor cardiopulmonary reserve, that limited heart and lung capacity, his deconditioning from inactivity, and his chronic pain.
Okay.
These are the core things that would make undergoing major abdominal surgery and that whole demanding recovery profoundly difficult for him.
And so the ultimate recommendation from this comprehensive assessment was?
The bottom line was that Mr. R is currently considered a poor candidate for surgical resection.
Right.
The assessment basically determined that the exceptionally high risks for him likely outweigh the potential benefits, especially given how slow-growing that tumor is and how it's behaved so far.
How did Mr. R himself feel about all this? About the recommendation and his situation?
The material's very clear here. Mr. R is currently very firm. He is not interested in surgery.
Okay.
He said he enjoys his life as it is, and he's content, happy even, that the tumor has been stable while they've been watching it.
But his daughter, understandably perhaps, brought up a point about the future.
She did. She voiced a really valid concern. What if the tumor does start growing later? Could that make surgery even harder, or maybe impossible, down the line? She framed it as a potential window of opportunity for surgery that might eventually close.
Yeah, I can see that.
It really highlights those difficult long-term timing decisions you get with slow-growing problems in older patients. It's tricky.
How did the clinician respond to that specific concern from the daughter?
Well, the clinician acknowledged her point about possible future scenarios. Made sense.
Sure.
But they gently steered the focus back to the present reality. Mr. R's current status. They emphasized, look, the tumor hasn't shown recent growth. Mr. R is currently very clear he does not want surgery.
Right.
And that actually, from the clinician's viewpoint, they were more worried about the potential impact of Mr. R's other health conditions on his well-being than they were about the immediate threat from this very slow-growing tumor.
Were any future possibilities discussed? Like, what if things change?
Yes. They did outline what might happen if Mr. R's view changed later, or if the tumor started acting differently.
Okay.
That would mean another in-person visit. They acknowledged the limits of maybe doing this remotely.
Right.
They'd try to optimize his other medical conditions as much as possible first.
Makes sense.
Then there'd need to be a reevaluation if future scans showed significant growth. They mentioned maybe a 10-20% increase as a trigger for discussion.
Got it.
And then they'd have more talks with the surgical team to rebalance those risks and benefits at that new point in time.
And how did Mr. R and his daughter seem to take all this? The assessment, the conclusion?
The sources say they appeared happy with the consultation, with the clarity of the assessment.
Good.
They seemed reassured that these decisions aren't set in stone. They could be dynamic. And they were told the geriatric oncology team would still be available if, down the line, Mr. R decided he did want to explore what they called potentially safe surgery, which of course really depends on his health at that future time.
Okay. Stepping back from Mr. R's specific case then, what are the broader takeaways here? What's most valuable for you listening, trying to understand these complex decisions?
Well, I think this case just powerfully demonstrates why a really thorough geriatric risk assessment is absolutely fundamental when you're considering a surgery for an older adult.
Yeah.
It hammers home that the decision is never just about the disease, the tumor here.
Right.
It's fundamentally about looking at the whole patient. Their functional status, day-to-day abilities, their complete list of other medical conditions, their history, how their bodies handled stress before, like Mr. R's previous surgery, their underlying physical resilience, their current quality of life, as they define it, and crucially, their own goals and priorities for their remaining time.
And how does that whole picture then feed into the actual decision?
That's where shared decision-making is paramount.
Yeah.
You have to bring the patient, their family, fully into the conversation.
Right.
Lay out the nuanced risks, the potential benefits, clearly.
Yeah.
Honestly, it's really the only ethical and frankly practical way to reach a decision that truly aligns with what matters most to that individual at that stage of their life.
Yeah.
Balancing the medical options against their overall health, their life priorities.
This deep dive into Mr. R's case, it really shows how these medical decisions, even something seemingly straightforward like removing a tumor, just become incredibly complex once you factor in the full reality of a patient's life.
Right. Their history, their current state, what they value. It's not just the disease in a vacuum.
You shared these sources because you wanted to understand these nuanced situations, and hopefully, by walking through Mr. R's journey with us, you can see how all these different pieces, a past medical event, a physical limitation, even a personal view on quality of life, they all fit together. They guide a decision that aims to be the best fit for that specific person.
Exactly. It's personalized medicine in a very real sense.
And it leaves us with a really challenging thought, doesn't it? You know, Mr. R isn't interested in surgery now. The risks are clear, high, and he values his current life.
Right.
But his daughter raises that powerful idea that the window of opportunity potentially closing later.
Yeah.
How do we ethically, practically navigate that tension? Right. Balancing that urge to act now against a potential future problem, with respecting a patient's current wishes and avoiding really significant immediate harm, especially when the disease itself, like Mr. R's tumor, is moving so slowly.
It's a tough balance.
It really makes you think deeply about time, about risk, and about what well-being truly means, not just medically, but, you know, in the context of a whole life being lived.